In a high-stakes environment of a coronary care unit, pulmonary artery catheters, often referred to as Swan-Ganz catheters, remain a gold standard for dissecting complex shock states. While non-invasive tools are great, sometimes you need the raw data that only the Swan can provide. Here is a simplified breakdown of pulmonary artery catheter hemodynamics and the clinical significance of pulmonary capillary wedge pressure. As the catheter travels from the right atrium to the pulmonary artery, each stop provides a specific pressure reading that tells a story about the heart's volume and function. CVP or RI pressure, normal range is 2 to 6. It represents the right ventricular preload or fluid status. Right ventricular pressure 15 to 25 systolic and 0 to 8 diastolic, RV systolic and diastolic function. Pulmonary artery pressure 15 to 25 systolic, 8 to 15 diastolic. It provides the pulmonary vascular resistance afterload indication. Pulmonary capillary wedge pressure 6 to 12. It indicates left ventricular and diastolic pressure LV-EDP. The pulmonary capillary wedge pressure is the holy grail of pulmonary artery catheterization because it allows us to look through the lungs to see what is happening in the left side of the heart. When the balloon is inflated, it occludes a small branch of the pulmonary artery. This creates a static column of blood between the catheter tip and the left atrium. In the absence of mitral valve disease or pulmonary vein obstruction, pulmonary capillary wedge pressure is almost equal to left atrial pressure, which in turn is equal to left ventricular diastolic pressure. A low pulmonary capillary wedge pressure less than 6 to 8 millimeters of mercury suggests hypovolemia, which could be due to dehydration or hemorrhage. High pulmonary capillary wedge pressure more than 18 to 20 millimeters of mercury suggests left heart failure or fluid overload. They can go in for pulmonary edema. High pulmonary capillary wedge pressure with low cardiac output is the classic signature of cardiogenic shock. The pulmonary artery catheter is most useful when you aren't sure why the blood pressure is low. In cardiogenic shock, the CVP is elevated, pulmonary capillary wedge pressure is elevated, and cardiac output is decreased, but systemic vascular resistance may be increased as a compensatory mechanism. In hypovolemia, CVP is reduced, pulmonary capillary wedge pressure is reduced, cardiac output is reduced, and there is a compensatory increase in the systemic vascular resistance. In distributive shock due to sepsis, CVP is decreased or normal, pulmonary capillary wedge pressure is decreased or normal, cardiac output can be increased in the early stage, and systemic vascular resistance can be reduced due to vasodilatation. In obstructive shock, as in pulmonary embolism, CVP is elevated, pulmonary capillary wedge pressure is decreased or normal, cardiac output is decreased, and systemic vascular resistance can be increased. Here are some very important practical tips. Leveling the transducer. Always ensure the transducer is at the phlebostatic axis, that is the mid-chest level. If it's too low, pressures will be falsely high. Respiratory variation. Always read the pressure at end expiration. This is when the pleural pressure is closest to atmospheric pressure, giving you the most true intracardiac reading. The A and V waves. Watch for large V waves on the wedge tracing. These often indicate acute mitral regurgitation even before you hear a murmur. While pulmonary artery catheters provide incredible data, they carry risks. Arrhythmias, pulmonary artery rupture. Always correlate the numbers with your clinical examination and echocardiography.